As is the custom, I will introduce the team by the name of the client organization only to avoid any biases, etc. And so our fourth presenter is the United States Center for Disease Control and Prevention.
Thank you and good afternoon. My name is Stephen Wassilak. I'm the team lead for Science, Innovation, and Research for the CDC's polio response. CDC is the part of the U.S. Department of Health and Human Services responsible for health protection and disease prevention. We are an international reference center for epidemiologic and laboratory science. I'm delighted to talk with you about how the Global Eradication partners use operations research and management science tools to make better decisions. While many people in this room may remember polio, for those who do not, polio is an ancient scourge caused by a virus with 3 different serotypes, 1, 2, and 3. So it's really 3 diseases. As wild polioviruses spread, most infections do not lead to any symptoms, and paralysis, or the disease called poliomyelitis, is a relatively rare outcome that occurs in less than 1% of infections in fully susceptible individuals. However, for those unlucky victims who become paralyzed, the virus destroys nerve cells in the spinal cord, which prevents movement of the corresponding limb muscles, primarily in the lower extremities. In most cases, this leads to permanent disability. Devastating polio outbreaks once terrified communities in the United States, with the virus striking otherwise healthy people without warning. Some polio patients do not survive because paralysis of their respiratory muscles leads to respiratory failure. Prior to the development of polio vaccines, hospitals in the U.S. maintained large, expensive polio wards with iron lungs, like the ones you see here, and some patients needed these for their lifetimes. Following intensive research efforts by Drs. Jonas Salk and Albert Sabin, the polio vaccines introduced in the 1950s and the 1960s changed the world. In the U.S., people lined up to get vaccinated, and the numbers of reported cases dropped significantly. CDC led the efforts that successfully stopped wild poliovirus transmission in the U.S. in the 1970s. This motivated the start of intensive campaigns in the entire Western Hemisphere in 1985, resulting in complete elimination of polio in the Americas. In 1988, world health leaders resolved to eradicate wild polioviruses and rid the world of polio by the year 2000, which led to the creation of the Global Polio Eradication Initiative, or GPEI, by 4 spearheading partners: the World Health Organization, or WHO, Rotary International, CDC, and UNICEF. CDC provides both technical and financial support to the GPEI. Our technical contributions include strategy development, disease surveillance, research, and service as a reference laboratory. We fund vaccine purchases, the laboratory network, field operations, and analytics. The GPEI uses 3 key programmatic strategies to stop polio transmission. First, routine immunization services provide vaccine to children in clinics at specific ages. Second, supplemental immunization activities, or SIAs, are mass campaigns that take vaccine out into communities with the aim of vaccinating as many children as possible within days. Finally, surveillance tracks the spread of poliovirus by searching for paralyzed children and then testing their stool samples in accredited labs. The GPEI supports countries using donated funds and by providing technical advice, but countries maintain responsibility for their own performance and they make their own decisions, which means a large number of decision makers. At the launch of the GPEI in 1988, polio was paralyzing people in more than 125 countries. And by 2001, the global surveillance system reported polio cases in only 10 countries. All of the efforts by countries and the GPEI led to an estimated 99% decline in polio cases between 1988 and 2001 and the eradication of type 2 wild poliovirus. With all of this progress, the partners began discussing plans for the polio endgame. In late 2001, CDC began a collaboration with analytics experts at KidRisk Incorporated to combine our laboratory science and epidemiologic expertise with operations research and management science tools. The collaboration sought to model poliovirus transmission and assess the health and economic impacts of policies. We recognized that we would need to iterate and learn together and develop a living model that we could adapt as situations, knowledge, and choices evolved. And we focused on the ultimate goal of improving evidence-based decision-making globally. In the public health community, to be truly effective, analytical insights need to withstand the rigors of peer review and be broadly shared with a wide range of stakeholders. The KidRisk website provides summaries and technical information about the more than 35 publications produced by the collaboration to date. We will next hear from the leader of the GPEI, who could not be here today, after which we will discuss the challenges and problems that we faced at the start of the collaboration.
Hello and greetings from the World Health Organization headquarters here in Geneva, Switzerland. I'm Dr. Bruce Aylward, the Assistant Director General at WHO, responsible for polio eradication and our work in emergencies. The Global Polio Eradication Initiative represents the largest global public health project ever undertaken, with an expected budget of about $1 billion a year over the next 5 years. We work hard to use our limited resources as efficiently and effectively as possible as we strive to find, reach, and vaccinate every last child in the world. I want to thank the Edelman judges for recognizing the incredibly important analytic contributions of the work that you are about to hear about. This work has been fundamental to so much of what's happened in the eradication program over the last few years, and it's helped to support many of our decisions over the last decade and to bring the world much, much closer to one where future generations will never know the terror of this disease.
My name is Dr. Mark Pallansch, and I am the Director of CDC's Division of Viral Diseases. At the time our collaboration with KidRisk began, the GPEI had made considerable progress, but it had missed the target and lacked the resources needed to finish the job. The GPEI partners increasingly realized that eradicating wild poliovirus types 1 and 3 and making a transition to a polio-free world were still complicated and challenging goals. In some countries, the challenges relate to inefficiencies in the immunization programs, while in others, security and inaccessibility issues play a key role. At the start of the collaboration, we recognized that exportation of polioviruses into previously polio-free countries could lead to outbreaks, which occur when a country does not maintain sufficiently high immunity to prevent transmission. As you can see, this challenge continues, with 50 different countries reporting polio cases between 2001 and 2013. While the number of endemic countries shown by the red squares continued to decline, the number of polio-free countries that suffered from outbreaks increased, as shown by the blue diamonds. Even in the last year or so, 7 countries experienced new outbreaks, including importations from Pakistan to the Middle East and from Nigeria to the Horn of Africa. Some of these countries had been polio-free for more than 15 years. Any disease control effort requires a surveillance system to monitor progress and trigger outbreak response efforts. Over the past 30 years, colleagues and I have helped to build and support the Global Polio Laboratory Network, which represents the largest disease surveillance network in the world today. We cannot detect most poliovirus infections because, as mentioned, most infections in fully susceptible people do not cause symptoms. In addition, immune individuals can become asymptomatically reinfected and participate in transmission. Thus, as immunization coverage increases and cases decrease, the surveillance system that relies on detecting the clinical symptom of paralytic polio reveals only the tip of the iceberg of the true number of infections, and widespread transmission can occur in any given community before an outbreak gets detected. As overall immunity increases and the surveillance system detects fewer cases, tracking the virus becomes more difficult, and we need analytical models that can help us understand transmission in the absence of detected cases. Countries and the GPEI use polio vaccines as the primary tool for eradication and for managing population immunity. Population immunity represents the aggregation of individual immunity. By achieving high enough levels of population immunity, the virus dies out, and maintaining these high levels will prevent transmission following an introduction. Countries can choose between two different types of polio vaccines for their national immunization programs, and both vaccines provide lifelong protection from paralysis. However, the two vaccines differ significantly with respect to their costs, risks, and the protection they provide from infection. The oral polio vaccine, or OPV, is the primary vaccine used by the GPEI. The benefits of OPV include its low cost and ease of delivery. Since OPV is a live attenuated virus, it causes an infection in vaccine recipients, who can spread their infections to other people, which provides or boosts immunity. Because OPV causes an infection, it provides good protection from reinfection, but its use comes with some risks. First, OPV causes very rare vaccine-associated paralytic polio, or VAP, in approximately 1 in a million vaccine recipients, which pales in comparison to the risk of paralysis associated with wild polioviruses. However, once wild polioviruses no longer pose a threat, the risk of VAP from OPV may become unacceptable, as occurred in the U.S. Second, in 2001, the laboratory network made an important discovery about OPV. Following investigation of a polio outbreak in Hispaniola, we documented the ability of OPV to revert back toward both neurovirulence and transmissibility of wild polioviruses. Specifically, in the absence of circulating wild polioviruses, populations with low vaccine coverage can begin to accumulate enough susceptible individuals to sustain the transmission of OPV-related viruses. These viruses can continue to evolve and cause outbreaks of circulating vaccine-derived poliovirus, or CVDPVs, that behave like wild polioviruses. Most of the developed world uses the inactivated poliovirus vaccine, or IPV. In contrast to OPV, IPV does not cause infection in the vaccine recipient, which means no VAP or CVDPVs. However, IPV costs significantly more to produce and administer, and global supplies remain limited to those willing to pay the relatively high costs. Moreover, IPV only protects the vaccine recipient. Because of its properties, IPV might not provide enough population immunity to stop transmission in poor hygiene settings, because it does not spread to contacts or provide as much protection from subsequent participation in asymptomatic transmission as OPV. All of the complex dynamics of 3 different polioviruses, stochastic events, and 2 different vaccines give you a sense of the challenges we face managing population immunity and eradicating polio. All of this feeds into the question that launched our collaboration: what will countries need to do in the polio endgame to successfully transition to a polio-free world? At the time our collaboration began, it was not clear whether the GPEI would raise sufficient funds to succeed. The strategy and policy decisions for the endgame about vaccination and other choices have high stakes, both in terms of financial and human costs, and numerous stakeholders need to cooperate. Next, Dr. Radboud Duintjer Tebbens, Vice President of KidRisk, will describe the approach and methodology we use to model the options for managing polioviruses in the endgame. First, however, we will hear from our co-author, who could not be here today, about the challenges of managing multiple stakeholders and a major landmark in the GPEI.
Namaste from Delhi, India. I'm Dr. Steve Cochi of the Polio Eradication Team. I'm sorry I'm not there in Boston with you. I'm attending an exciting event here in Delhi to mark another major milestone in the global fight against polio. The event is the official certification by an independent regional certification commission and the celebration of more than 3 years without any polio in the entire 11-country Southeast Asia region of the World Health Organization, which includes India, Bangladesh, and Indonesia. Globally eradicating a human disease represents a tremendously challenging and complex task. The world is large and complicated, and polioviruses can spread quickly without any respect for international borders. Some of the biggest challenges that we face with any global health initiative relate to ensuring good cooperation and coordination across the many organizations and governments that are involved. The CDC provides extensive technical, laboratory, and programmatic support to countries around the world. At the launch of this collaboration, it was very clear that the polio endgame would be far from simple, and the world would need to develop effective policies and strategies based on the available and often imperfect evidence. We recognize that to support the decisions of individual countries, we would need to understand where they were starting from and consider the options from their perspectives. Countries differ significantly, both with respect to their risks and their resources, and this variability complicates global decision-making. In addition, we're talking about charting the course for the future, which is inherently uncertain. We needed to develop a rigorous analytical model that could account for variability, uncertainty, and time as it provided insights that would help to align the Global Polio Eradication Initiative partners and other stakeholders to develop strategies that would realize the ultimate goal of a world free of polio. So here in India, I'm happy to report that these strategies have yielded tremendous real-world results. And as of today, it has been officially certified that another nearly 2 billion people live in a now polio-free region of the world.
As we set out to model post-eradication policies, we found that there was no common understanding about the policy choices and that this really complicated discussions among the stakeholders. This immediately suggested the use of decision trees and influence diagrams to bring structure to the problem. We developed this summary decision tree that conveyed the 7 categories of options that national leaders would face after global eradication. Multiplying the number of branches in each category yields a total of 6,144 decision options. However, we recognized some critical dependencies between these choices and the reality that the initial conditions in the country would determine the options that national health leaders would consider. For example, countries currently using OPV would consider these 96 options, while countries that use IPV would consider these 256 options, and those who would expect to stop polio vaccination altogether would consider these 768 options. Recognizing this variability made it clear that a single global analysis that treated all countries the same would not work. Therefore, we stratified our analysis according to the World Bank income levels to account for the variability in conditions, risks, and costs between countries. To help the GPEI make evidence-based choices as it considers the health and economic outcomes associated with different policy options, we used 2 different metrics that matter to our decision makers. The first metric involves minimizing the incremental cost-effectiveness ratio, which divides the incremental cost of the policy compared to the status quo by the incremental cases prevented. We translate polio cases into disability-adjusted life years, or DALYs, to account for both morbidity and mortality. The second metric involves maximizing the incremental net benefits, which requires that we monetize health outcomes. For global health challenges like polio eradication, quantifying the inputs of these seemingly simple equations involves a lot of complexity, and no single ORMS tool can do the job on its own. Therefore, we integrated different ORMS tools to build a model that can handle the complexity. Specifically, we use decision analysis to frame the problem, probabilistic risk analysis to capture uncertainty and random events like virus reintroductions, and system dynamics to model the dynamics of poliovirus immunity and transmission and other time delays and feedbacks in the system. When our collaboration started, health economic analysis primarily estimated cases using static or linear models, which do not account for the externalities associated with immunization. Combining dynamic disease models with health economic models in the context of a real global health policy represented a major methodological advance, and further integrating the two with probabilistic risk analysis represents the cutting edge in global health policy modeling. We use this high-level influence diagram to communicate about the model components with policymakers. The decisions on the left influence the conditions in different settings, most notably population immunity. The decisions also influence the risks of post-eradication outbreaks, both directly and through population immunity, as well as the financial costs. The cost, population immunity, and risks all involve substantial uncertainty that we characterize using distributions for model inputs. For the probability of virus reintroductions, we modeled 86 time-varying Poisson rates that depend on the decisions. To predict the expected cases following a potential poliovirus reintroduction in an unprecedented world free of any immunity derived from OPV or wild poliovirus, we used system dynamic tools to account for the dynamic interaction between virus prevalence and population immunity. Finally, we combined the cases and costs into economic estimates using established guidelines for health economic analyses. For technical publications and internal discussion, we used this more traditional influence diagram to explicitly identify the decision nodes, random events, dynamic submodel, intermediate variables, and outcomes. The diagram also reveals more of the mechanics of the model by showing which components depend on time, World Bank income level, and random draws from the input distributions. We also adapted this overall integrated model for future post-eradication policies to address current policy choices related to achieving eradication and to look retrospectively at the costs and benefits of choices made in the past. To give you a sense of some of the mathematics behind the model, let's take a closer look at the dynamic model we use to characterize outbreaks. Using a large set of differential equations, this model accounts for the accumulation of individuals with different types of recent or historic immunity from the wild virus or the two different vaccines, for the spread of OPV from vaccine recipients to contacts, and for the feedback loops that govern the characteristic exponential growth and decay of epidemics. This model has 25 age groups, and each of these includes 5 immunity states with a 2-stage infection process for a total of 325 stocks or state variables. We use numerical integration to solve the equations and generate estimates of polio cases that could occur as a function of the policy choice and time. We assess the model performance by simulating various historical outbreaks and verifying that the model behavior was consistent with the evidence about those outbreaks and about poliovirus immunity and transmission. As we began to model potential future outbreaks, the question of how the GPEI should respond to outbreaks naturally arose. To address this question, we simulated hypothetical prospective outbreaks to look at the trade-off between timeliness and coverage of the outbreak response. We found that many fewer expected cases occurred if the GPEI responded faster with lower coverage for the first round than if it delayed the start of the response until it could expect higher coverage for the first round, as illustrated by the areas between the curves, which represents polio cases prevented and lives saved. As soon as we shared our preliminary results of this analysis with the GPEI, it communicated the insights broadly in its primary newsletter sent to stakeholders called Polio News. Following a comment about the programmatic importance of these insights, Dr. Kimberly Thompson, the president of KidRisk, will present other key results and impacts of our work.
Seeing and understanding the trade-offs between speed and vaccination coverage for the first round of polio outbreak response really shifted our way of thinking at the global level and eventually translated into real changes right down to the field level across this entire global program, which was operating in over 72 countries around the world. We focused, as a result of this analytic work, on working with our partners to find ways to ensure that we could more rapidly mobilize resources and respond faster. As a result of this analytic work, we had to change our global polio outbreak response policies, and we had to challenge our teams in the field and in the lab to look for opportunities to really reduce the time delays in the system so that we were operating much, much faster. This work clearly demonstrated that speed trumps coverage at the beginning of an outbreak response. And that was a fundamental shift in the way people were approaching polio outbreak response. And that translated in turn into a fundamental shift in the speed with which we could shut down outbreaks and our ability to maintain international confidence in this program, but most importantly, to prevent additional kids from getting paralyzed. Now, most indicative of the depths of the impact of this new understanding on our work is that it underpinned a World Health Assembly resolution, a resolution that was agreed by over 192 ministers of health who were gathered here in Geneva back in the mid-2000s. And for the first time ever, to issue internationally agreed guidelines for polio outbreak response by which countries would be bound and operate going forward. This was a huge shift and one of the big shifts in the way the program began to operate as we intensified the initiative in the mid-2000s.
Although we produced many important insights, we focus here on 4 key studies that we published using our integrated modeling. In the first integrated analysis, we quantified the health and economic benefits of the past, present, and expected U.S. investments in national polio control and elimination efforts. The blue line shows our estimates of the numbers of cases that occurred associated with the actual path the U.S. took, which compares well to the reported cases shown in the gray bars. We also used the model to show the expected cases that would have occurred if we had not made those investments, shown with the red dashes. The difference between the red dashes and the gray bars shows the human health benefits of our investments, or represents the human health benefits of our investments. We also demonstrated the misleading and significant underestimation of the benefits that would come from using a static model, shown with the green dashes, which only accounts for direct protection of vaccine recipients. This work was the first to methodologically demonstrate the importance of using a dynamic disease model to correctly estimate the economic metrics the health economic metrics for a real and significant public health decision. More importantly, we found the investments were cost and life-saving, and we estimated incremental net benefits of over $180 billion, which helped to strengthen U.S. support for both domestic and global investments. Our second integrated analysis focused on post-eradication vaccination strategies. We characterized the risks of the post-eradication options and different World Bank income levels, as well as the starting points of population immunity. Here you see a few of the 86 time-varying Poisson rates per 100 million people that we characterized based on the available evidence. We used Monte Carlo simulation of the stochastic risks to characterize the different possible futures after the eradication of wild polioviruses. We simulated the total number of outbreaks for the 147 countries in the 3 lowest World Bank income levels each year over a 20-year period. You could see the different realizations helped the decision makers see the difference between the chart on the left, which shows the outbreaks with continued OPV use after eradication, but without SIAs that would keep coverage high enough to prevent CVD-PVs, compared to the chart on the right that shows the risks if the world coordinated cessation of OPV after successful eradication. This analysis showed the partners that they needed to expect and prepare for outbreaks, and that continued OPV use without maintaining high coverage after eradication would represent the riskiest option with the highest expected numbers of outbreaks. We found that CVD-PVs represented the most significant risk immediately after eradication, and that continued use of OPV with low coverage after eradication is not a good epidemiological option. Building on these results, we performed 10,000 stochastic iterations of the post-eradication vaccination policy options for each income level to obtain distributions of the total costs and cases, which we used to identify the optimal options. We reported expected values and 5th and 95th percentiles of costs and cases aggregated over 20 years, discounted at a 3% rate, which showed that after successful eradication, globally coordinated OPV cessation represented the best policy option, with or without IPV. IPV offered the lowest expected number of cases, but the highest costs, and we highlighted the need to reduce the cost of IPV to make it a more cost-effective option in the future. This analysis suggested that continued use of OPV after eradication was not a good economic or health option. To provide further context, we also used a game theoretic approach to demonstrate the critical importance of globally coordinating OPV cessation to minimize exportations of polioviruses across borders, and we demonstrated the need for a vaccine stockpile to support outbreak response efforts. This work supported a World Health Assembly resolution to coordinate OPV cessation. Of course, in order to stop using OPV, we first need to complete eradication. In 2006, while we were working on the post-eradication analysis, some stakeholders began questioning whether continued investment in polio eradication made sense, and whether we could even stop polio in very difficult places like northern India. We used our model to simulate the situation in India and showed the dynamics of stopping wild poliovirus circulation as a function of the different levels of immunization intensity. Specifically, if India just increased its coverage to the threshold level required to eventually stop polio transmission, shown in the blue curve, then it would take a very long time. But with increased intensification of immunization, transmission stops within a few years. Our results showed that India could stop polio, and that failure or success and the time it would take to succeed depended on the intensity of immunization efforts. The government of India significantly intensified its immunization efforts in 2007 and reported its last polio case in January 2011. In the context of the high-profile suggestions that the GPEI should abandon eradication and switch to control, we characterized the expected costs and cases associated with the various control options for all low-income countries over a period of 20 years, using the same simulation approach we used for the post-eradication model. The results of this analysis demonstrated that control implied high cases and low costs, or low cases and high costs, as shown in the upper right part of the gray box, but not low cases and low costs. We compared these to the post-eradication results, shown here with blue squares, which demonstrated that eradication represents the better option. Also, with the questioning of eradication, we considered the impact of a wavering commitment. We extended our system dynamics model to add a negative feedback loop with a first-order time delay between reaching a certain cost per case threshold and the resulting change in immunization intensity to simulate a wavering commitment, as shown here. Using this model, we compared the strategy of vaccinating intensely until things look good and then wavering, as shown in red, to a strategy of vaccinating intensely until eradication, shown with blue dashes, or until sometime after eradication, shown with green dashes. Tracking the cumulative costs on the left and the cases on the right, we see both strategies at first start with intense vaccination, so the curves for the costs and the cases overlap. However, once we reach the point of high costs per case, under the red strategy, immunization becomes less intense and the costs accumulate more slowly. At first, with respect to the cases, we don't see a difference. But after building up enough susceptible individuals with the less intense red strategy, an outbreak occurs leading to more cases. At that point, the cost per case drop below the threshold, and we intensify immunization, which makes the cost lines parallel and again slows down the accumulation of cases. This analysis clearly showed that such oscillations would lead to greater accumulation of costs and cases over a 20-year period for a wavering commitment than a strategy that aggressively pursues immunization, at least until sometime after eradication. Now, in summary, we found that wavering is more costly with respect to both costs and cases in the long run. In response to the questions from stakeholders about control versus eradication, the WHO Director General, Dr. Margaret Chan, called for an urgent stakeholder consultation in February 2007, during which, in reference to our work, she's told attendees that they would be, quote, seeing today new data that show why, over a 20-year period, every proposed option for controlling polio will cost more in human suffering and dollars than finishing eradication. In other words, getting the job done is your best buy. Finally, we performed an economic analysis that characterized the expected costs and cases with and without the GPEI, considering all of its past and expected future efforts. This analysis estimated net benefits of $40 to $50 billion for the GPEI for polio alone, and more if we include the benefits of vitamin A delivered during polio SIAs. Dr. Carol Pandek, who is the director of Polio Plus for Rotary International, said, quote, we regularly use the $40 to $50 billion estimate of net benefits of the GPEI as we raise funds to finish polio eradication both within and outside of Rotary. The modeling work made a compelling case for stable and sustained funding, and this helped all of us as we plan ahead. In April 2013, the Bill and Melinda Gates Foundation organized a vaccine summit that raised $4 billion to support the GPEI for 2013 to 2018, which was celebrated by all of the partners. Dr. Aylward offered the following comments on the importance of this work.
Seeing the risks of circulating vaccine-derived polioviruses, or CVDPVs as we call them now, seeing these risks quantified for the first time supported our efforts to use evidence-based planning for managing these CVDPVs going forward. It was particularly important in making the case globally for eventually coordinating the cessation of the use of the oral polio vaccine, which would require getting consensus and coordination across 140 countries around the world. And this work was fundamental to help building the evidence base that people would agree to coordinate and synchronize such a massive activity around. These concepts represented a huge strategy shift from the original vision of the world's leaders who had not foreseen the challenges we'd have and the need to manage those risks with the same rigor that we were bringing to the eradication of the wild virus itself. The estimates that were generated in terms of both the human and financial costs of control of polio as compared to eradication of the disease laid to rest any doubts about the benefits of eradicating this virus. These results became fundamental to the case for completing polio eradication. And also, it's been fundamentally important to helping us bring in new partners to this program. At a time when most people have forgotten polio, I simply can't overstate how critical it was to have these numbers to illustrate the gains of completing polio eradication and the benefits of eradication over control.
We continue to expand our modeling efforts to answer critical questions for the polio endgame. Our presentation today simplified a great deal of complexity that our current modeling efforts address. Our methods and approach can easily be applied to the management of other vaccine-preventable diseases, and we are already working on analyses related to measles and rubella. In addition, as computational power continues to increase, we expect to see much greater use of integrated ORMS tools and specifically dynamic and probabilistic simulation. We believe that successful models will require true collaborations between subject matter and analytics experts. CDC used the findings and insights from our collaboration to progressively bring structure and important insights to discussions with the GPEI partners about eradication strategies and managing the endgame. The models, with evolving complexity, allowed the partners to address major challenges facing GPEI, and they saved both lives and money. In summary, this work contributed to creating a future in which children who otherwise would have been paralyzed by polio will run, jump, play, and enjoy healthy and productive lives. We acknowledge many contributors to this presentation and those who contributed to this technical work. In closing, Dr. Aylward offered the following comment.
Informed by epidemiologic and economic data, it's very, very clear that mathematical modeling can give us an idea of the future and potential costs and impact of our policy options. It is both fed by the past data, but more critically, informs our future planning. As other teams create analytic models to support decision makers who manage complex systems, I can vouch for how transformational these are for strategic and program planning.
Thank you.